Can you hear me okay?
Yes, we can hear you. So let me officially introduce Dr. Asim. He's the consultant anesthesiologist and the intensive care personnel at the University of Sydney Concord Clinical School. So we welcome Dr. Asim Shah. Dr. Asim, please, I really am sorry if I have given a wrong introduction of yours because that's the introduction which I have of yours. So you can please introduce yourself as well. And we welcome you from the platform of Pakistan Society of Anesthesiology, Karachi chapter. Please go ahead.
Yes, thanks, Asma. That was all good. The only thing I would say, I'm not an anaesthetist. I just work in intensive care, so just do intensive care medicine. Thanks for having me. It's always a pleasure to connect with Pakistan. I've been to Pakistan several times in the last few years, and yeah, I love going there and eating the food and meeting other people. So I'll start off with this talk. It's on severe burns in intensive care. Now, everyone does burns differently, and I'm sure there's a huge amount of expertise in Pakistan in this field, as there is in other areas of the world, some more than others, unfortunately. So this talk will focus mainly on the Australian experience. This is what I'll present is how we practice the management of burn in Australia. And we will go through the Australian system. And this is also how we teach burns in Australia as well through one of our courses, which is the emergency management of severe burns. Okay, so in this talk, if you want to interrupt me to ask any questions, please do so anytime or at the end. But we'll go through the initial assessment and resuscitation of severe burns. I'll talk a bit about the physiology and pathophysiology, because I think that's really important to understand what effect burns has on the body, and then from there it's actually easier to understand our management sort of approaches. Okay, so the initial assessment resuscitation, we'll talk a bit about airway management, how we do airway management in Australia, some fluid resuscitation, which there is, I'm sure, will be some questions, and there's lots of controversies there. We'll just revisit burn area and depth. Again, everyone does this differently, so we'll explain how we do this in Australia. And then there'll be some ICU management talks as well. It's such a big area that I just didn't think there'd be enough time to cover everything. So there's also lots of areas that I haven't covered, such as chemical burns and electrical burns, but there just wouldn't have been enough time, I think. Okay. So, severe burns is one of the most difficult challenges in the intensive care unit. These patients are some of the sickest patients that you will find in any intensive care unit. There's life-threatening instances throughout the admission, not just at the beginning, or there's just several, stages where there's a life-threatening process going on. There's pain, there's distress, there's changes to the appearance of the patient, their functional state, their loss of independence and future employment, psychological issues, huge impact on their long-term quality of life. And of course, the families are hugely affected as well. So it's very difficult to find a patient like this in ICU. So the burns patient is very complex and quite specific. Just the organization of burns in Australia. We have an overall overarching burns service. So it's a very much a multidisciplinary team. The teamwork is extremely important. The burns service consists of this public health, which is probably the most important part. The public health, their education and their plans when there are bushfires are extraordinarily important in reducing the incidences of burns. And so it's really important to have a very, very good public health service. And then there's the pre-hospital, the ambulance services, and they're very highly trained for first aid in burns and then transport to the burn centres, both by air and by road, because it's a huge country. So there's pre-hospital teams, and then in the hospital, in the emergency departments, everyone's quite highly trained in burn centres and also in non-burn centres as well to effect the initial first aid and resuscitation. And then there's operating theatres with special burns surgical teams, burns nurses, burns anaesthetists, and also, yeah, often there are plastic surgeons. And then patients go to the burns ward with the special burns multidisciplinary teams. There's nurses, there's allied health, physiotherapists. Everyone's really important. And then, of course, the burns ICU, where we have an expertise in the management of severe burns, which you probably wouldn't find in a non-burns ICU. So this is the burns team structure. There's also other parts as well. There's chronic pain teams. There's acute pain teams as well. There's pain specialists. And there's, plastic surgeons as well for ongoing care. So this is an overall look at how burns is structured in Australia. Yeah, so just to touch on the epidemiology. So worldwide, it's the fourth most common type of trauma. In Australia, they say about 1% of the population will suffer from burns every year. Of these, 3 to 4% are hospitalised. 16% of those hospitalised are severe burns. Now, severe burns is defined as more than 20% of total body surface area in adults and more than 10% in children. Okay, and of these hospitalised, about 5% of them are admitted to ICU. So there's quite a small number that actually come to ICU, but these, as we said, are some of the sickest patients around. Okay, so that's just a bit of background. Now, it's really important to understand, I think, what the skin does is when you start, and I mean, I'm sure all of you know this, but when you start thinking about what the skin does, then it's easier to understand what happens when the skin has been burnt and damaged. So the purpose of the skin is control of fluid loss, there's temperature regulation, there's physical protection, mechanical, chemical, thermal. It's a barrier to infection, one of the most effective barriers to infection in the body. It's an immune organ as well. It's a sensory organ, and importantly, it's your face. Psychologically, it's your interface with the rest of the world. So psychologically, your skin, the appearance of your skin, is extraordinarily important. Okay, so we'll move on to responses to burn injury. Now, there'll be local responses and then there's systemic responses. So locally, if you have extended exposure to temperatures more than 40 degrees, you'll start getting some tissue damage, protein denaturation, the cell plasma membranes will be damaged, and this eventually will lead to cell necrosis. And this process starts within 1 hour of exposure to 45 degrees centigrade, but only 1 second of exposure to 60 to 70 degrees centigrade. So the important thing is the duration and the heat. Okay. So both of these are very important, the duration of time that you're exposed and the temperature. Okay. Now, again, this is a very important slide. So there's 3 zones, and there's a chap called Jackson who came up with this burn wound model. I think it was in the 1950s. And there's 3 zones. So there's, first of all, there's a zone of hyperemia, which is quite superficial. And if you have burns in this area, burn injury in this area, this usually recovers quite well. Yeah. And then underneath that is the zone of stasis, where there is more damage. There are more blood vessels and other structures, that nerves that can be damaged, and this results in danger to the viability of the tissue. But if you look after this area well, there is some potential recovery. And then finally, there's a zone of coagulation where there's irreversible necrosis and complete destruction of tissue. And this is where you can't really do much in terms of recovery. Okay, so it's quite important to understand these three zones. Okay, so the important zone is the zone of stasis. When we resuscitate and manage acute burn injury, the main aim is to prevent the zone of stasis turning into the zone of coagulation. And this is something that is somewhat under our control. We can't really control what happens in the zone of coagulation. It's too late by then. But in the zone of stasis, there is still some hope. If you don't do anything, it usually does progress onto cell death and becomes the zone of coagulation. So there is a window of time in which we can intervene to try and prevent this. So in the zone of stasis, there's the usual inflammatory mediators, and these are all the usual cells, inflammatory cells, mast cells, macrophages, and the usual chemicals, such as histamine, serotonin, oxygen-free radicals. And all of these cause essentially an increase in vascular permeability. And that's what is a hallmark for the morbidity in burns. Increase in vascular permeability causing tissue edema, and then going on to cause vascular damage, vascular occlusion, and then tissue necrosis. And then we have the systemic inflammatory response. And we, in Australia, we accept that in adults over 20% and in children more than 10% of severe burn injury. At this point, we think the amount of inflammatory mediators released causes clinically significant systemic effects. So not only are there local effects, but then the systemic effects. And these systemic effects are most importantly seen in the vascular tissue. So in unburned tissue, there's widespread increased vascular permeability because of these inflammatory markers. So if you have on the burn site, there's going to be, obviously there'll be some damage there, but in a distant site that's not burnt, you'll also see increased vascular permeability. And this leads to generally loss of fluid and proteins from the intravascular space to the third space, and results in significant edema at the burn site and also around other areas of the body. And we'll touch on this later, especially in the airway section. So this edema is the most severe in the first 12 to 24 hours. And this is the time when there's potential for severe hypovolemic shock. All right. I'll just I thought I'd mention what happens at the capillary because this, even though it sounds a bit boring and not really that sort of like exciting really, but I think it's quite important to just touch on what happens at the capillary level, because it really helps you understand the pathology of burns and what we're trying to treat. So at the capillary level, there's diffusion of smaller molecules across the capillary membrane into the extracellular fluid. There's filtration, which is driven by hydrostatic pressure. That's the pressure of water pushing things out, and pressure of water on the other side pushing things in. And then there's large molecule transport, which we don't really understand. But essentially, this is what keeps albumin in. And then when the capillary wall gets stretched, you think that albumin starts escaping outside into the extracellular fluid. And that's really important. That part's really important because it's the large molecule transport that's most affected in burns. And this leads to albumin escaping into the tissues and then the oncotic pressure goes from intravascular space. And this, is really one of the reasons why there's so much edema and intravascular depletion in the early stages. Right, so other systemic effects, cardiac output's reduced in the beginning due to myocardial depressant factors. There's decreased blood volume for the reasons we just mentioned. So reduced venous return, and this is all in the first 24 to 48 hours. After this, cardiac output actually increases with a hyperdynamic state, and that's due to the inflammatory markers and of a sympathetic effect from the sympathetic nervous system. We'll talk about that a bit later. So on the respiratory side of things, there's an increase in pulmonary vascular resistance, but acute pulmonary edema may occur if you give too much fluids. Usually it doesn't occur as a direct consequence of burns, but usually it's iatrogenic. And then there's renal impairment, acute kidney injury due to hypovolemic shock compartment syndromes and systemic inflammatory response syndromes. And surprisingly, there's a high incidence of gastrointestinal tract bowel ischemia, bowel edema, bacterial translocation, and sepsis from the bowel. We've actually had to do a hemicrectomy on one of our patients recently because of this. Okay, all right. So now we'll move on to the initial assessment and treatment of burns. So we categorize burns into 3 types of patients. So there's patients who have an isolated burn, and then there's patients who have a burn with an obvious other injury, usually trauma, and then there's a burn with a concealed other injury, which is not obvious. So the important thing in this slide is that when you see a patient with burns, it's very easy to get distracted by the appearance of the burn, and you can quite easily miss traumatic injuries that are possibly life-threatening. So the actual appearance of the burns can be so dramatic that you sort of get carried away with the burns treatment, but they can be quite, especially depending on the mechanism, like a road traffic accident or explosions, or even high voltage electrical injuries. In trauma, there could be life-threatening traumatic injuries. So our approach really has to be combined with a trauma systems approach. So the initial assessment treatment is going to be similar to trauma, but with a burns sort of slant to it. So we'll just go over that now. Right, so this is what we teach here in Australia. It's the early management of severe burns. So you look at everyone will be familiar with this, but there's just a few things that are slightly different. So there's the airway, the breathing circulation, disability. And
If you behave like this.
Sorry, what was that? Did somebody say something? Okay. So
I would request everyone to mute their microphones so that we can have Dr. Asim clearly. Otherwise, then we'll have to mute everyone ourselves. That would cause trouble for most of the organizers and also for Dr. Asim. So kindly mute your microphones. Sorry, Dr. Asim, you can continue now.
Yeah, that's right. Yeah, thanks. Yes, and then but at the exposure stage, this is when we estimate the total body burn surface area, and then that's what's used to calculate fluids. So then we have fluids, the fat area we check for first aid as well at that point, and then we do a secondary survey. So this is a very important slide. This is how we structure our burns assessment. And it's very important to recognize that it's almost identical to the trauma assessment, because it's really easy to miss life-threatening traumatic injuries when you have a burns patient. All right, now, so the first thing is the first aid. So stop the burning process. If somebody's on fire, there's a you stop them, you drop them, you ask them to get onto the ground, you cover them with something or a blanket or something, and then they have to roll over, and that's the easiest way to get them. If you have any heat resistant blankets or anything, but just really anything, just roll them, ask them to cover themselves and roll. And it's important for them to cover their face, okay, so that there's their area is protected and there's minimal facial burns. So you stop them, ask them to drop on the ground, cover them with the blanket, cover their face, and get them to roll. Okay, so that would be quite dramatic. I'm sure some of you might have done that. Then you cool the burn wound. We'll talk about that later, but this is effective up to 3 hours. And it's running cool water. It's for about 20 minutes. The water temperature should be around 15 degrees. But the main thing is it shouldn't be too hot and shouldn't be too cold. And the really important thing is not to use ice or iced water. So if you use ice or ice water, this actually extends, this causes vasoconstriction and extends the burn injury. Okay, so this is one of the most important stages of preventing the zone of stasis converting to the zone of coagulation, as you mentioned earlier. Okay, so we'll just go through the primary survey. So this is based on the ATLS, the protocol. So the airway and cervical spine, breathing, ventilation, oxygen, circulation with hemorrhage control, disability assessment, and then environmental control. But at the end of that, we estimate the percentage of total body surface area that's been affected by the burns. Okay, so the airway, so check for patent airway. You talk to the patient, listen to their voice, see if there's airway is clear. If it's not clear, look for any foreign material or anything that you might be able to suction out. Do your usual simple maneuvers for the airway, head tilt, chin lift, jaw thrust, or you might not want to do head tilt if they have C-spine injuries. You can use airway adjuncts with oropharyngeal and nasopharyngeal airways. And then the important thing about a burns patient, which is different to a trauma patient here, is that you should always consider early intubation. And this is really important as it becomes more difficult later if you think you have a borderline airway, it's much better to intubate earlier, because after fluid resuscitation, the first sort of 12 to 24 hours, it can become, the airway can become really edematous. It can be very difficult to intubate afterwards. So it's trauma principles, but the burns specific issue is early intubation will be far easier often if you have an airway that you think is compromised. or if you're worried about it. It's always better to intubate early than extubate, rather than have a difficult airway and not be able to intubate 24 hours later. Yeah, and don't forget about the C-spine. So with breathing, yeah, just as much oxygen as you can, 100% high flow oxygen. Look, listen, feel the chest. I follow the rates mnemonic, which is look at the respiratory rate, auscultate, see if the trachea is midline, assess the effort of breathing, and look at the saturations. You go on to exclude pneumothoraces, hemothoraces in events of of trauma. You can, if you're worried about ventilation, you can give some bag valve mask ventilation or intubate, as we discussed earlier. But in breathing, the burn specific issue that you don't want to miss is a circumferential chest burn. If you have a circumferential chest burn, you won't be able to increase your thoracic cavity by inspiration. So your ventilation will be, your inspiratory volume and your ventilation will be severely restricted. So you must look for a circumferential chest burn at this stage. And if you see something that's restricting chest wall expansion, you may have to consider an escharotomy. So the burn specific issue here is circumferential chest burn. And just moving on to circulation, there's hemorrhage, intercostal drains, all the usual stuff. But the specific thing for burns here is when you're checking for pulses, just check all 4 limbs. It's really important to check the pulses in all 4 limbs, because this will give you a clue whether there is some circulatory compromise in any of the limbs, and you might be able to pick up a circumferential injury. So it's really important to check pulses in all the limbs. Yeah, so then you get IV access bloods. You just the usual bloods. So moving on to disability, we use the AVPU, which I'm not sure if you're familiar with. It's quite easy, just to see if the patient is alert, they respond to voice, they respond to pain, or if they're unresponsive. It's just a shortened version of the Glasgow Coma Scale. And then, yeah, look at the pupil's reaction to light and size. Disability is the burn slant to it is if there is any altered level of consciousness, you have to be very suspicious of, apart from hypoxia, you have to be very suspicious of inhalation of toxins such as carbon monoxide or cyanide or some other toxins that are affecting the patient systemically. Okay, so in any altered conscious state, just think of inhaled toxins. Exposure. So keep the room warm if possible. Remove all the clothing because the clothing can be a heat reservoir that can keep making the burn worse. Keep the patient warm, because remember the skin's one of the main roles of the skin is temperature regulation. Do a log roll just to have a look at the back. And then at this point, you estimate the total body surface area that's been affected by the burn. And we'll come to that. We'll come to that at the end of the talk. Right. And then we move on to the fluids. So we follow the modified Parkman formula. So this has been changed recently, and for an adult, it's 3 mils per kilo times the total body surface area that's affected. And a child is more than 10%. But in a child, you have to add maintenance fluids as well. We use Hartmann's mostly. You can use normal saline, it's fine as well. And then there's Plasma Light is another fluid that's sometimes available even in Australia. It's more like a balanced fluid. Warm your fluids if you can, a fluid warmer, and then the the volume that you've calculated using the Parkman formula. You give half in the first 8 hours. And it's important to do this to calculate this from the time of the burn, not the time of arrival to the hospital. From the time of the burn, half in the first 8 hours, then half in the following 16 hours. And this recognizes the huge redistribution of fluid that we discussed earlier that happens immediately when you have the burn. This is all the capillary leakage and the movement of albumin and fluids into the third space, which is quite dramatic in the first few hours. Okay, so this recognizes that. And then a urinary catheter is probably the most common way we monitor fluid resuscitation. We aim for 0.5 mils per kilo per hour. There are a few other things we can use as well, which we'll come to later. But the simplest and easiest way is to just follow the urine output. Okay. So analgesia. So everyone will be doing different things, but here mostly we recommend just giving some morphine, 0.05 to 0.1 mils per kilo. You titrate to effect. Obviously, there's lots of different ways of giving analgesia. So this is just one way of doing it. You do all the blood tests. Just to remember, carboxyhemoglobin is important here. And then just the usual trauma X-rays and CTs. And yeah, urinary catheter, nasogastric tube if it's required, especially in intubated patients. And then we move on to the secondary survey, which is the usual history, taking the history, allergies, medications, past medical history, last meal, and events. You may need to do collateral history or see if there's any witnesses around for this, or wait for family. And then head-to-toe examination, especially the eyes, inside the mouth, looking for blisters or soot. And now, the important thing is this might require frequent re-evaluation. You might want to repeat the primary survey if something changes. And then the secondary survey, you may need to repeat it a couple of times, particularly pulses. When you're looking for, when you're assessing all the limbs, you may need to check all limb pulses several times, because remembering when you're giving fluid resuscitation, there'll be a lot of edema, and if there's a partially circumferential burn in a limb with edema, that can become circumferential. So you really have to stay on your toes when you're giving fluids, and you may have to repeat your secondary survey a couple of times. And then finally, document everything, reevaluate primary and secondary surveys, and don't forget the family. They'll be very distressed. So lots of family support. Maybe allocate somebody from your team just to stay with the family. Okay, so that's a summary of our structure of the initial approach to a burns patient. Very similar to trauma, but there's a burns issue in each of these sections that is quite specific to burns patients. All right, good. So we'll just keep moving on. As I was saying in the beginning, there's so much to cover in burns. I won't do much of it justice, but I'll sort of crack on with the main things that I thought were important. So the next thing, inhalation injury. Everyone goes on about inhalational injury, and it's one of the most feared complications, because it's so hard to manage. We think we see it in about 1/3 of patients with severe burns, especially with hot gases, steam inhalation, smoke chemicals. Classically, it's a fire in an enclosed space. So if you're trapped in an enclosed space, you should have a very high suspicion of an inhalational injury. And the important thing with inhalational injuries are that there is at least a twofold increase in mortality. Yeah, so we classify it above the larynx, below the larynx, and then systemic toxicity. So supraglottic, and then the lower tracheobronchial tree, and then the lung parenchyma, and then the toxins that affect systemically. Right, so the upper airway injury is usually due to steam or hot gases. The injury is similar to the mucosa as a cutaneous burn. There can be rapid swelling over a few hours that can lead to airway obstruction. So you really have to keep reassessing the trajectory of the injury and the trajectory of the edema, and intubate early if there's any suspicion of increasing level of airway obstruction, especially with fluid resuscitation. And remember, upper airway injury can occur, coexist with lower airway injury. If the steam, for example, if it gets inhaled so fast that it goes into the lower airways as well, it can cause both upper and lower airway injury. So below the larynx is usually toxic chemical inhalation. So all the toxic chemicals in smoke and also carbon particles, soot. So this gets mixed up with all the fluids in the lung, and either becomes acid or alkali or both. This leads to hyperemia of the mucosa, increased microvascular permeability and edema. You also get some sloughing and proteinaceous exudate, similar to early ARDS. And then you get airway casts causing mucus plugging and bronchopulmonary segments that can have atelectasis and collapse. And all this obviously can cause quite severe bronchoconstriction as well. Okay, so this is below the larynx. And then you can have lung cell damage. This usually manifests as non-cardiogenic pulmonary edema. This is usually in quite severe inhalational injury, and you can get lots of microvascular clots and increased pulmonary hypertension. There'll be infiltrates, and the lungs will just get stiffer. So there'll be decreased compliance. And then this will eventually go on to a full ARDS picture. And then systemic toxicity, there's carbon monoxide and cyanide are the main ones. I'm not sure which, whether these are common in Pakistan, but usually it's from furniture, and plastic furniture and foam furniture. And then there's all these other chemicals as well that are in various combustion chemicals from various pieces of furniture. Okay, so how do you diagnose inhalational injury? History is very important. The heat source, if there's a lot of smoke involved, and if it's in an enclosed space. Also, the level of consciousness will give it away. We just have got a table for everyone. I'm sure you're all quite familiar with this. So just look for burns to mouth, nose, pharynx, any singed hair, any soot, and then any difficulty in breathing. And then you listen for hoarse cough, change in voice, stridor, wheeze. Okay. And then there are some clues which can tell you whether the injury is above the larynx or below the larynx. If it's above the larynx, the timing is very quick, and the signs are usually changing your voice, drooling, and stridor. And then at the lower airways, it takes a bit longer, and it's usually pulmonary edema, hypoxia, and ARDS. And then the systemic toxicity is usually, if it's going to do anything, it usually does things immediately at the scene, so it's potentially fatal at the scene. So the management, again, the main thing is if you're worried, just intubate early. We don't mind patients coming to ICU that we extubate the next day. We do it all the time, but it's better that you don't try and sort of take risks before they get to ICU, because then it can become very difficult to intubate them. All right, so next thing that's the airway part done. So we'll just quickly move on to burn shock and fluid resuscitation. So shock happens very early, hypovolemia, reduced cardiac output. Your urine output will decrease, and you'll become quite shut down and have reduced peripheral blood flow. And the first thing you need to do is make sure you assess the depth and the size of the burn. And this gives you the information to estimate how much fluids to give. So epidermal burns are not included. So if it's very superficial burns like sunburn, don't include that for your percentage total body surface area for calculating fluids. So modified Parkman formula, as we mentioned, 3 mils per kilo. The weight, half in the first 8 hours, half in the next 16 hours. You monitor the urine output is the easiest way to see if you're resuscitating effectively. If the urine output is too low, just increase the fluids by 10 to 20%. Or if they're high, if the urine output is high, then you can decrease the fluids. We also follow the lactate, and hematocrit can be useful as well. So these are other markers that you can follow. Choice of fluid, this can be a bit controversial, but crystalloid is standard, saline or Hartmann's. In the first 24 hours, no clear evidence for albumin. However, we do tend to use it in large burns. If you just go back to the physiology, the pathophysiology we discussed at the beginning of the talk, this is why I think it's important to understand that, because it is albumin that escapes into the tissues, and there's a huge loss of aquatic pressure. So in the larger burns, we do tend to, in our unit, use albumin, 20% albumin quite a lot, and 4% albumin as well. And there's no clear formula, but we often default to 1/3 albumin and 2/3 crystalloid if there's a really large burn in the first 24 hours. Yeah. So there are problems as well with fluid resuscitation. There's elderly patients, and especially with patients with cardiac disease, and fluid creep, when every day you just add on more and more fluids. So there can be a patient with a huge amount of fluids by the end of the week. Some patients will need extra fluids, and these are trauma patients, inhalation injury patients, and patients that have had delayed resuscitation. And one important thing is if the urine is dark, if you think there's myoglobinuria due to rhabdomyolysis and a high CK, then you will want to aim for a higher urine output to protect against acute kidney injury due to the high CK. All right, okay, so we're almost done now. Last question soon, but the burn wound assessment. So you first assess the depth and then the size. You want to assess the depth first because epidermal burns are not included for fluid resuscitation purposes, and it's only dermal or full thickness burns that you're really interested in. Okay, so this is the dermis, epidermis, and then there's subcutaneous fat. As you can see, the dermis is just got keratinocytes, and most of the skin structures around the dermis. There's lots of different ways of assessing burn depth. There's people have different stratification models. We use this one in Australia, so it's superficial, superficial partial, mid partial, deep partial, and then full thickness. The superficial is epidermis, and then the other ones are dermis, and then full thickness is down to the subcutaneous fat. So the epidermal burn is just damage to the epidermis only. It's just red skin. Capillary refill is good, and this heals very easily. Okay, and this is an epidermal burn. Yep. Superficial dermal is slightly more, so there's some blisters present now. But again, with some dressings and moisturization, this heals quite quickly. So this looks a bit more impressive, but this is still something that you'll be able to manage it quite easily. In mid-dermal, as damage just extends out a bit more, so it does affect more skin vessels, blood vessels, and other structures. The capillary refill is less, but they might require surgical intervention. So this needs a referral to a surgeon. Okay, this is mid-dermal. Okay, then deep dermal, deeper layers of the dermis, but not the entire dermis. Lots of blotchy red white skin. So this is a lot of zone of hyperemia and stasis. Sorry, zone of stasis is being converted into the zone of coagulation here. This definitely needs surgical intervention. And this is it. So it's lots of patches of white that are turning into the zone of coagulation. And then the full thickness burns are destruction of the entire dermis and underlying tissues as well, as white, waxy, cherry red sometimes, or brown or black, and no capillary refill, and you need surgical intervention here. And this is some cherry red, it can be white, it can be black. So this is a full thickness. Okay, so that's the depth. And then the area we use, mostly we use the Wallace rule of nines. Also the Palmer surface model, when you use the palm of your hand to measure small areas. And then there's London Bowel chart as well, which you can use. There's various measuring machines as well. And then there's an actual app on your iPhone. You can get an app on your iPhone, and then you can use that to map it as well. So that's there's a few different ways of estimating the area. Okay, so finally, we'll just talk a few slides on care in the ICU. So the timing of surgery, we like early surgery, but there's no consensus amongst the surgeons. eschar, like dead skin, it's a source of inflammation. It's a source of inflammatory mediators, which makes the patient sick. It can be a reservoir for sepsis, for bacteria. And so we do try to get rid of eschar early. And then going on from there, sepsis surveillance is really important. Frequent dressing changes. In the first week, sepsis is quite unlikely, but the nurses do like dressing changes either every day or every other day, and they're very experienced at looking at any areas of skin that are looking like they're getting infected. So we continue organ support, early treatment for sepsis, rotate the central venous lines because they get infected quite easily. Fluid monitoring, daily weights is probably the best thing. So we have weights, we can check the weights on our beds electronically, but there's lots of other ways of doing it as well. Transthoracic echoes, if they haven't had their chest burnt. You can use transesophageal echoes, but it's quite invasive. Picos are quite good, but again, they're very invasive because you need a femoral arterial line and a internal jugular line as well. We use lots of albumin every day. So there's daily albumin, sometimes 200 or 300 mils of 20% albumin. We find that the analgesia and sedation balance is really important. So we very quickly go into a high analgesia regime and minimize sedation. And then we use this to try and extubate patients early. So this is very important to get your analgesia and sedation balance right. It's very easy just to sedate them because you think it's going to be better for their pain. But if you actually give them sufficient analgesia, you don't need to sedate them, and then they can be extubated early, which is really good for the patient. Other things that happen in the ICU is nutrition. Nutrition is extraordinarily important. There's lots of equations telling you how much feed to give. This is they're all as good as each other, but none of them are very good. The best way to calculating nutrition requirements is indirect colorimetry, which is what we use in our unit, and this gives us an idea of their energy requirements. We also minimize fasting. So for dressing changes and theatre visits, we don't stop sedation. unless there's going to be an abdominal operation, or if there's going to be any airway, if they're not intubated, or if it's going to be an airway exchange or a tracheostomy. Otherwise, we don't fast them. So this is has made a big difference in their nutritional balance. To help with that, we tend to use nasoduodenal feeding, so there's less of a risk of aspiration when they go to theatre. Yeah, usual trace elements, especially zinc. Physiotherapy, we do physiotherapy as soon as the patient's extubated. There's a team of burns physiotherapists who are exceptionally good. Occupational therapists are very important to prevent contractures, especially in the hands and the legs and the limbs. And the speech therapists are extraordinarily important because there's a huge number of inhalational injuries that are more subtle, and it's only after extubation that you can be aware of these, and then this affects their aspiration risks and aspiration pneumonia risks. So speech therapy. So it's a huge team afterwards in ICU that is required to look after these patients. And I just wanted to, I like this ebb and flow phase. So there's two phases in the burns. The first 24 to 48 hours, it's called the ebb phase, where the metabolic response slows down. So we mentioned the all those cardiac depressant factors and reduction in volume, and so this leads to a reduced metabolic rate in the first 24 to 48 hours, and then the metabolic rate just shoots up. And at this point, you really have to match the patient's nutritional requirements, energy requirements. So the dietitian will have to come and completely change their feeding regime, nutritional regime at this stage. And this high metabolic phase can go on for like a year or more in the bigger burns. So this is a very long-term thing. Okay, so we're almost finished. I think we've got 2 minutes left. So severe burns, one of the most challenging group of patients in ICU. Early resuscitation organ support in a structured manner. Accurate percentage calculations for your fluid resuscitation. Surveillance for sepsis. So whenever you do dressing changes, just keep looking at changing your lines, keep looking at the skin, and doing surveillance skin swabs. Early extubation, which is facilitated by less sedation and more analgesia. Nutrition is one of the most important things that will get the patient out of ICU. And in all these fields, more research is needed, because there is a huge amount of variable practice in burns ICUs, just even across Australia, never mind across the world. So this was just a snapshot of what we do and we teach here in Sydney. I thought there's not a huge amount of evidence for any of this, but I think this is probably as good as any approach to this quite sort of difficult area. And this is a picture of Sydney with the moon. This was taken, I took it during Ramadan, and so that's the Ramadan moon over Sydney. And
thank you so much, Dr. Asim, for your extensive and elaborate talk. So you were mentioning about carbon monoxide poisoning. That's quite common in Pakistan as well, because of the materials which have been used otherwise. And we have quite some questions in the chat box. Do you want me to read it out for you? Sure. So Mr. Mohammed, Dr. Mohammed Javed Khan has asked that 4 to 3 ml per kg of the fluid, any role of the colloid after 24 hours. And he has also asked, what are the symptoms with different levels of carbon monoxide?
Yep, sure. Okay. So the first question with colloid, absolutely, after the first 24 hours, we use a lot of albumin. the glycocalyx is disrupted, the cell membranes, and so albumin keeps escaping. And so to maintain the oncotic pressure and also to reduce tissue edema and reduce crystalloid requirements, we give daily albumin. I'm not sure how easy albumin is to get in Pakistan, but I would definitely only use albumin and not use any synthetic colloids. So it's no synthetic colloids, but just albumin. So that's the first part. Now with carbon monoxide, yeah, so carbon monoxide poisoning. So there's you become like your skin becomes very cherry red. You have a bounding pulse. You sort of become more and more confused, agitated, and then this then leads on to CNS depression and coma, and then you die. So the initial phases when you find.
So does the different levels of carbon monoxide, do they coincide with the symptoms? Like at different levels, the symptoms are different, or are they the overall the same?
A system, it's more of a sort of neurological effect, but it gets worse and worse. So you might start off with mild confusion, and then this will just progress to more sort of pronounced confusion, then agitation, and then you can have you slowly go into a coma, and it's just the higher the dose, or the longer the dose, longer the dose is high, the levels are high, you'll just get more and more sort of a effect on your level of consciousness.
All right.
So
and
you will be able to pick it up quite early.
Okay. And we have another question from Hagdad Durrani. He's asking if adult has burn less than 20% and a child has burn less than 10%. What would be the fluid administration in both of them?
Yes. So so in this situation, there's less of a risk of having a systemic inflammatory response. So your unburnt tissue will not have the increased vascular permeability. So you won't have a third space fluid loss in your whole body. So it's more reasonable to just again go. You will need to give some fluid, but the best way to do it is just to go by a urine output, just a half a mil per kilo per hour, is a fairly sort of a universal target. But you don't need to follow the Parkman formula, because you'll end up giving too much fluid then.
Okay, so this also is connected with this other question which has been asked by Dr. Naseem Javed, and he's asking that then how would you manage the fluid resuscitation in a pregnant female with the severe burns, or those patients who have congenital heart problem or the renal failure problem? So how will we be assessing the fluid, adequate fluid resuscitation otherwise? Because initially you had said that we will monitor the urine output of 0.5 mL per kg of the body weight. So in patients who already have compromised kidney failure, kidney function, or those who undergo the kidney failure, how are we gonna assess the fluid management in such patients?
Yeah, so that's a very good question. So this leads to a higher degree of complexity and a higher degree of interventional modes to assess fluid, the body, the fluid composition. So when if you have, for example, an acute kidney injury or chronic kidney disease, and your urine output is not going to be reliable, it's very easy to over-resuscitate, and it's very easy to give far too much fluid, which will usually cause problems such as pulmonary edema and difficulty ventilation. So it is very important to have other means of assessing your fluid balance. And so we tend to use echocardiography a lot. I'm not sure how familiar you guys are with point of care echocardiography, but I tend to use the left ventricular outflow tract velocity time integral times the left ventricular outflow tract diameter to assess the stroke volume. And this is quite easy to repeat. So it's quite a lot of anesthetists are quite familiar with this. It's quite easy to measure, and it's quite easy to repeat after giving a fluid bolus. So that's one way of immediately at the bedside assessing fluid status and fluid responsiveness. If you can't access the chest with a probe due to burns, then it gets more difficult. We often use PICOs, which it's a thermodilution technique. So there's you need an internal jugular central venous line and an arterial femoral arterial line with a thermistor, and it just measures temperature differences around the body after giving some cold fluid at the top. So it measures your temperature difference, and that gives you an indication of the cardiac output. So that's another way of doing it, but it's quite invasive. And then there's the esophageal Doppler as well. Some centers use that. We don't have much experience with that. And if you don't have any of these, then I guess just looking at the lactate and the chest X-ray, making sure repeated clinical examinations, looking for complications of fluid overload are probably the best that you can do. Just looking for signs of pulmonary edema, signs of just overall peripheral edema, and then stopping resuscitation, stopping aggressive resuscitation. If you're finding that there are signs that there's progressive pulmonary edema or peripheral edema, I think that's probably what you would end up doing if you didn't have access to the more invasive techniques.
Right. So there is another question by Dr. Abab Jahangir. Is asking, a burn patient comes with abdominal trauma requiring urgent surgery. What would be the anesthetic concerns and the perioperative management? I think that's altogether a whole topic on which another, I think, class or a lecture can be taken. But would you like to give a few and a quick summarized solution to his question?
Yeah, so this is I think this just goes back to the structure that we have for the initial assessment of these burns patients. It's very easy to get carried away with the burns itself, but the burns won't immediately kill them. If there's a life-threatening traumatic injury, or if there's an abdominal injury that's life-threatening, that has to be assessed first. There are going to be challenges with fluids during the anesthetic. Fluid balance will be a far higher risk of hypovolemic shock or a vasodilatory shock due to SIRS. Those are probably the two main things. So it's fluid balance and vasodilatory shock are probably going to be the main things that you have to be prepared to manage, I would say. But it's the burn itself is not going to be what's going to kill the patient in the first 24 hours. It will be the abdominal trauma or the whatever's happening in the abdomen. So that needs to be fixed.
So we have another question by Anam Anwar. She's asking, what is fluid creep?
Oh, yeah. So, excuse me. So fluid creep is when you give some fluids and then the next day you've resuscitated the patients there, then the fluid sort of starts redistributing again. And then you sort of end up giving another couple of liters the next day. And then cumulatively over a week, if you're not following the fluid balance closely, you might suddenly end up with like 10, 15, 20 liters positive fluid balance. And that's what's called fluid creep. You don't actually, unless you're paying very close attention to it, all these small fluid boluses and will every day will all add up. And then next thing you've got a patient who's 20 liters overloaded with huge level of sodium in their blood from all the fluid and the saline, and it's very hard to get rid of then. So that's what's called fluid creep.
Thank you so much, Dr. Asim. So we have another question. Shall I ask it before closing the session for today?
Sure. Yeah.
Okay, thank you. So Dr. Naseem Javed has asked, maybe I think you have already mentioned that. He has asked about a burn patient. I'm sorry, I'm just repeating the same question. So this is actually Muazzam Ali Shah, and he has asked about the fluid resuscitation controversies like sodium chloride and hyperchloremic acidemia by some fluids. So can you please shed some light on that? And also, there is another question by Livingstone, and he's asking, what is the fluid management beyond acute phase? Kindly shed more light. So these are the two questions, and then we will be closing the session for today.
Yeah, okay. So the issue with hyperchloremic acidosis with normal saline, that's very real. Because we use a lot of albumin as well, but the albumin is comes with a high chloride content as well. It's a normal saline. So there is a real danger of having a non-anion gap metabolic acidosis, in addition to all the other acidoses that you're going to get with burns. Whether the hypochloremic acidosis is affects mortality or not, I don't think there's any evidence on that. It probably does affect morbidity, but the ways to minimize it, I guess, would be more research and experience with other balanced fluids such as plasmolite. So in the future, that might be something that's going to be looked at. But yeah, there's a real danger of having a huge chloride, huge chloride dose in the first few days. And the second one was the second question was fluid management after the acute phase. I think that was the question. Yeah. So.
Yeah, that's right.
Yeah. So. The easiest thing to do is just follow the urine output. We just follow aim a target of 0.5 mils an hour pretty much for the first 2 or 3 weeks in a major burns. If we're in doubt, that's what we target, and we usually keep our heads above water with that. And then, yeah, there's lactate, there's hematocrit as well. Hematocrit can be quite useful, especially the trend. And then echocardiography or PICOs. I think that's what, depending on your skill set, that's what people tend to use. But yeah, keeping euvolemia and preventing kidney injuries is a very high priority following the acute phase.
So one last question by Dr. Kashif, and he's asking about the pain management in severe bung patient.
Yeah. So pain management. So this is really important. So we give multimodal analgesia. So there's usually fentanyl infusion, so opioids, fentanyl and morphine, but mostly fentanyl. We can reset it to oxycodone as well. There's paracetamol regularly. There's pregabalin, which we start after a few days for neuropathic pain, and then a ketamine infusion, often, especially during dressing changes. So ketamine we find is very, very useful, especially because of its non-respiratory depressant effects. Yeah, so usually a balance between opiates, paracetamol, having some pregabalin in the background, and ketamine, and minimizing benzodiazepines, like minimizing propofol, minimizing midazolam, and then slowly you're able to get a balance in which the patient is awake and has got a good level of analgesia.
Right. We actually in Pakistan, we are short of fentanyl, and we don't have morphine available. So most of the time we have either tramadol or nalbuphine in hand, and that's what we give to patients, especially nalbuphine, and yes, also the ketamine. So I think the take home is to give the opioid, but whatever is present in your country and in your circumstances, especially in the limited resources. But if you have got good opiate or the potent opiates, then obviously those are the drug of choices for such patients. So I'm really grateful to you, Dr. Asim, such a beautiful picture of Sydney, and thank you for sharing the not only the picture but also a great topic with us. And we hope to have you back again in some other topic from the PSA Karachi online lecture series. Thank you so very much.
Okay, it was a pleasure. Thank you.
Thank you, everyone, and have a good night. Thank you.